कोई बात नहीं. So we have a lot of elderly people around us in our family, in our society, and we see that there are multiple causes. Malnutrition. So they are vulnerable to malnutrition because of many reasons. First of all, most common in our society is your financial constraints. Second is your social issues, taboos. Taboos in the sense कि भाई मान लीजिए हम एक पर्टिकुलर रिलीजन को फॉलो करते हैं, सो वी हैव सम टैबूज कि भाई ये वो नहीं खाना है, मंगलवार है, व्रत है, ये सब चीजें. So they have propensity to develop malnutrition because of related physiological decline, reduce access to food, and then comorbidities, hypertension, diabetes, another issues. So in old, it can be reflected in terms of your involuntary weight loss, low BMI. These are the gross. हम कह सकते हैं कि साहब वेट बहुत कम हो गया, but there are some hidden deficiencies such as micronutrient deficiencies. They are difficult to assess and therefore frequently overlooked. In developed countries, most cited cause of malnutrition is disease, both acute and chronic disease, and therefore the higher the age is the one risk factor for developing disease. The older adults have a highest risk of being at the nutritional risk of or become malnourished. So clinical malnutrition predominantly occurs in the patient hospitals. That is, when you come to your clinical posting, you will see the patients in your wards and your ICUs who are being admitted for some comorbid illnesses, and they are here for say many days. You will see there will be a loss of muscle mass. In terms of your mid-arm circumference, mid-thigh circumference, and then आप देखेंगे तो hollowness of your loss of buccal fat and wholeness of temporal fossa is another clinical marker कि सब patient जो है वो malnourished हो चुका है. There is a loss of muscle mass. But what happened that in community dwelling old people, that is those are living in say in your old age homes or even in rural area houses, they are overlooked, and they are also suffering from their malnutrition. So have a serious implications. सीधी बात है, nutrition अच्छा नहीं होगा. They have a high propensity of developing disease. They have a high propensity of being admitted for various issues, and so in this way, this should be acknowledged as a serious burden to the healthcare society. So depending upon the type, protein catabolism can be pronounced. Therefore, disease-related malnutrition lead to a rapid skeletal muscle wasting, whereas age-related malnutrition associated with a slower but progressive loss of muscle mass. जब डिजीज होगी तो मसल मास बहुत तेजी से जाएगा, लेकिन जब एज रिलेटेड सार्कोपेनिया होगा तो मसल मास विल गो स्लोली. द इफेक्ट ऑफ प्रोटीन कैटाबॉलिज्म आर प्रीडोमिनेटली रिफ्लेक्टेड बाय द लोअर मसल मास, मसल स्ट्रेंथ एंड फंक्शन विद सीवियर implications of the physical performance. At the same time, malnutrition but also reduced dietary protein intake per se are associated with the decrease in the bone mineral mass. Because protein intake is usually associated with constipation, and elderly people, they have frequent issues with their digestive problems, so uh, they themselves associate some food with their complaints. दूध नहीं पीते हैं बहुत सारे लोग, बिकॉज जैसे जैसे एजिंग होती है इंटेस्टाइनल लैक्टेज आपका डेफिशिएंट होता जाता है, सो कंजम्पशन ऑफ मिल्क may lead to bloating, and hence slowly they start avoiding milk. Later on, non-vegetarian diet, which is also high in protein, including the eggs, they are again avoided by our elderly because of some psychological and some religious issues. So in this way, as the age progresses, the malnutrition and specifically the decrease in nutrient intake, especially protein intake, is associated with your increased bone mineral mass loss. So the contributors, that is first of all non-perishable items, यानी कि जो चीज़ खराब नहीं होती है, कुकीज़ हैं, नमकीन है, they all contain high amount of sodium and nitrates, and the processing lead to removal vitamins. तो क्या होता है कि अक्सर अकेले रह रहे हैं तो शाम का खाना कौन बनाए, तो they have a propensity कि भाई चलो थोड़ा सही खा लेते हैं. So the non-perishable food जो होते हैं, they have high sodium and nitrates, and they are deficient in nutrients. Drugs, which may lead to anorexia and gastric changes, and medications. ड्रग्स के दो नुकसान है, एक तो भूख कम कर देती है, दे लीड टू एनोरेक्सिया एंड गस्ट्रिंजेस, एंड ऑल्सो सम ड्रग्स दे इंटरफेयर विद द एब्जॉर्प्शन ऑफ द nutrients. So we have risk that so these are the risk factor for the poor nutrition, that is alcohol, cognitive dysfunction, decreased exercise, depression, financial limitations, inadequate funds, limited education, limited mobility, medical problems, medication, poor dentition, all those. दांत नहीं है कैसे खाएगा? So we have another issue is dentition. So in this way, finances, social beliefs, poor dentition, medication, social isolation, they all lead to your malnutrition in elderly. There are certain drugs. Out of them, your SSRI, antidepressant, they're commonly used. Furosemide, an important component of your anti-hypertensive medications. Theophylline, very commonly prescribed to your asthma and COPD, particularly COPD patients. Theophylline is basically a xanthine analog. Spironolactone, levodopa. Levodopa, you must have read, you are in second year, you must have read about your levodopa and carbidopa combinations, and levodopa lead to nausea, vomiting in the acute, and in chronic cases it will lead to your akathisia and other acceptable symptoms. Fluoxetine, which is specifically a antidepressant, and your metronidazole, commonly prescribed for abdominal infections, may lead to your anorexia. Then there are drugs which affect the gustations. Out of them, anitriptyline, that is your TCA, which is an tricycle antidepressant, dexamethasone, diltiazem, hydrochlorothiazide, which is an important part of your antihypertensive. You must have seen any some of your family members or your elderly patients taking your Telma H or Olmesar H sort of medications, which are used for your antihypertensives. Nifedipine, phenytoin. Nifedipine is a CCV. And some drugs which affect the infections include again amitriptyline, very common, enalapril, and then your morphine. So in this way, drugs which affect, जब स्वाद नहीं आएगा, smell नहीं आएगा, जैसा कि आपने कोविड में भी देखा होगा लोगों को, they can't eat. For them, the eating something is just like eating a clay, which is tasteless and odorless and difficult to eat. Now, drug nutrient interactions. Some of drugs they combine with the nutrient and they inhibit their absorptions. Like antacid, they will combine to your B12 and folate and iron. Diuretic combine with your zinc, magnesium, B6, and laxative combined with your calcium and vitamin A, B12, B2, and DEK. So in this way, the combination of antacid, diuretics, and laxative, they hampers their absorption from the intestinal tract. So this is how the alcohol leading to your B6 and folate and B12 deficiency. So when you will come in your wards, you will find that the pancytopenia के patients होते हैं, specifically B12. So most of them they have a history of chronic alcohol use. Antacids leading to your iron and calcium. Antibiotics. This is a common question. A patient है जिसको 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 15 days antibiotic दे रहे हैं because of some abdominal issue, and now he or she is having a raised INR. What can be the cause? So it is because of the production of vitamin K is decreased. Diuretics, laxatives, metformin, specifically diabetic patients, metformin बहुत commonly दी जाती है, and this will lead to your B12 deficiency anemia. So this is basically energy requirements. Estimated total energy need is 25 to 30 kilocalorie per kg per day, and this is the estimated energy needed, which can be predicted by the Harrison-Benedict equation. This is just a theoretical part, but almost we need a 25 to 30 kilocalorie per kg per day. So we, for a patient of, yes. Sir, how is it that the metformin and other drugs, B12 absorption is inhibited. Yeah, but sir, how does it do that? What is it about the metformin that causes the B12 to not be absorbed? How the metformin affect the absorption B12? Yeah. Okay. I will check it out. So carbohydrate should comprise 45 to 65% total calories, and fat should comprise 25 to 35% calories, and protein should comprise 10 to 35% of calories. Food intake should include 30 ml per kg per day or 1 ml per kg per calorie intake. So in this way, protein estimation, we need zero point 0.8 to 1.5 kilogram of the per day. But in the case of renal and hepatic involvement, we have to decrease the protein intake. Estimated estimation of fiber intake, we need 30 grams in a man and 21 grams of fiber per day. So nutrition syndromes, that is undernutrition, it is a third leading condition in the hospital and home care sites, and the fourth leading condition in the office practice and nursing home, for which the quality efforts would improve the functional health of the elderly patients. So undernutrition is often clinically difficult to distinguish between cachexia from the wasting. Cachexia you will see in your cancer patients. The resting energy requirement is high, or expenditure is high. And fasting, we have a resting energy expenditure is decreased. So obesity, again, obesity is another form of malnutrition. Usually obese seems to have overeaten, but it is not like that. It is under form of malnutrition. The prevalence extends from the 60 to 70 age group. Uh, Adverse outcomes associated with obesity includes impaired functional status, that is BMI more than 35, and increased healthcare resource use and increased mortality. Poor diet quality and macronutrient deficiency are common in obese patients, specifically women who live alone. So in elderly obese patient, the focus should be on the attaining a healthy weight to promote the improved function and overall health and quality of life. A combination of dietary change, behavior modification, and increased activity of the exercise are appropriate most of the elderly patients. Now, nutrition syndromes, homebound elderly are growing in number and among the elderly obese. For those with fear for frailty and obesity, the emphasis should be placed on preservation of strength and flexibility rather than on the weight reductions. So prevention is better than cure. So prevention is easier than treatment, and intake improved by catering to the food preferences. Avoid therapy. There are many diets, NASH diet, DASH diet are available. So rather than following the specific diet pattern, those food materials which are easily available and which are preferable to the patient, they should be provided. Prepare patient for meals with hand and mouth care, proper positioning. Assist those who need assistance. Use herbs and spices to compensate for the loss of senses of taste and smell. This is practically for homebound, bedbound patients who are ill from a long time and who need support for their daily chorus. Avoid rushing through a meal. Meals on wheels, this is not possible. It is basically US pattern. Meals on wheels, that is whenever and it is possible and whatever possible, they should be provided to the elderly. And along with that, we should give a micronutrient supplement, including the calcium and vitamin D. It has suggested that multivitamin antioxidants may help to prevent the age-related cataracts and the macular degenerations. So asked about the document of all medications. If we need, we have to review regarding the use of those medications which are causing the gustatory or olfactory losses, or which are responsible for your loss of appetite. Some appetite stimulants like mirtazapine, what is known as Remeron, the 3.75 30 mg per oral at the bedtime. It enhances serotonin by the antagonism of the 5-HT receptor. Or cyproheptadine, very commonly given by the practitioner in form of CYP-L, a common syrup which is prescribed by the pediatrician as well as the adolescent physicians, that to improve the appetite. It can be given orally with the meals. Serotonin and histamine antagonists with some anticholinergic properties and potential for confusion, because sedation is very common with these. These are basically antihistaminics. Sedation is very commonly associated side effect, so we have to look for that also. In summary, malnutrition is remarkably common in the elderly or older adults, and risk of malnutrition in the elderly is high even in the absence of clinical or social risk factors due to the primitive so-called anorexia of aging. Now, limitations in the functional capacity, dentition, and support system contribute to the problem. Medication can and do adversely impact the nutrient status. As we know, some may lead to gustatory changes, some may lead to the olfactory changes, and some may lead to the binding of nutrients to the drugs, so hampering their absorptions. Use of one or more screening tools can identify the undernourished individuals whose problems are amenable to the intervention. So this ends your topic. So